In this episode, I'm answering a listener question about how many contractions are too many contractions, as well as a medicine that's used to stop contractions called Terbutaline. Welcome to the All About Pregnancy and Birth podcast. If you're having a baby in the hospital, you are giving birth in a system that too often takes away power from women over what happens in their own bodies. I'm Dr. Nicole Rankins, a practicing board-certified OBGYN who's had the privilege of helping well over 1,000 babies into this world. I've been a doctor for over 20 years, and I'm here to help you take back your power, advocate for yourself, and have the beautiful pregnancy and birth that you deserve. This podcast is for educational purposes only, and it's not a substitute for medical advice. Check out the full disclaimer at drnicolerankins.com/disclaimer. Now let's get to it. Hello there. Welcome to another episode of the podcast. Whether this is your first time listening or you have listened before, I'm so glad you're spending some time with me today. In this short episode, I am answering a listener question, and today I am answering a question from Kat. She sent it to me via Instagram DMs, and the question says, "Hi, Dr. Nicole, longtime listener and love your podcast." Well, thank you for that, Kat. Question for you. A friend of mine recently gave birth to a beautiful baby girl, but unfortunately her birth didn't go as planned. She got to the hospital at 7.5 centimeters, got an epidural, and then they told her she was, quote, having too many contractions, 5 in 10 minutes, and the limit is 6. So they gave her Terbutaline to slow down her labor. I have listened to hundreds of birth stories and never heard of this. Then, of course, her labor stopped progressing, so they gave her pitocin a few hours later, and well, you know what happened after that. I'm curious if you could do a short episode on the drug they use to slow down labor. Curious how common it is and learning more about the 6 contractions in 10 minutes rule. I definitely had more than that with both of my births, but maybe it's because I didn't have an epidural. Thanks so much. Well, thank you so much, Kat, for sending this great question. I am going to tackle it all in this episode. And if you ever have a question that you want me to answer in an upcoming short episode, just let me know. Shoot me a DM on Instagram. I'm at Dr. Nicole Rankins, or you can send me a message on my website. There's a contact page there, and you can also reach out there too. Okay, so let's first talk about the too many contractions. That is something called tachysystole. And tachysystole refers to an abnormally rapid contraction rate, particularly in the context of contractions during labor. So this isn't like Braxton Hicks or anything like that. We're specifically talking about contractions during labor. And the definition is, as you mentioned, it's having more than 5 uterine contractions in a 10-minute period, and that's averaged over 30 minutes. So you don't necessarily look at just one 10-minute period. You have to look at it over a period of time, so average it over 30 minutes. Tachysystole can occur either spontaneously or it can occur as a result of labor induction or augmentation, which is just helping labor along with medications like pitocin or even prostaglandins like Cytotec or Cervidil. And when we see tachysystole, we may need to intervene to reduce the frequency of contractions to ensure the safety of both mom and baby. And that is because tachysystole, particularly with those contractions during labor, does pose some risk to both mom and baby. So for the fetus, it can cause something called fetal hypoxia. And what happens is frequent contractions can decrease the amount of oxygen that the baby receives. And this happens because blood flow to the placenta is reduced during contractions. So when that squeeze happens, the blood flow is reduced. And that can lead to decreased oxygen supply to the baby. And prolonged periods of decreased oxygen supply, so prolonged periods of hypoxia, can cause fetal distress, as you might imagine. Just like if we went for longer periods without oxygen, we're going to be under stress too. And that can be reflected by changes in the fetal heart rate tracing. And if it keeps happening over longer periods of time, then that reduced oxygenation can result in a buildup of acid in the baby's blood. That's a condition known as acidosis. And that can have some pretty serious consequences if it is not addressed promptly. So fetal acidosis can lead to immediate complications like respiratory distress or low APGAR scores, even neonatal encephalopathy. And then the long-term risk, if the acidosis is severe and prolonged, it can result in something called hypoxic ischemic encephalopathy, HIE, and that can lead to long-term neurologic damage, including cerebral palsy, developmental delays, or cognitive impairments. Now, when we look at the risk of tachysystole for mom, in the case of excessive or frequent contractions, there is a risk of uterine rupture, particularly in a woman who's had a previous cesarean birth, so has that old cesarean scar there, or in someone who's had other uterine surgery like a myomectomy, which is removing fibroids. That is also going to increase the risk of uterine rupture if there is tachysystole. Also, more frequent contractions can lead to greater pain and fatigue. It can be tiring, particularly if you don't have an epidural, to have those contractions be back to back to back to back, and you're not getting a break in between, because more than 5 contractions in 10 minutes is going to be like less than every 2 minutes for contractions. So you're just not going to have a break, and that can make labor more difficult to manage. Tachysystole can also increase the risk of placenta abruption. Placenta abruption is when the placenta prematurely separates away from the wall of the uterus. This can be life-threatening for both mom and baby, because for mom, it can increase bleeding. For baby, it's going to abruptly cut off the baby's blood supply and nutrients and oxygen and everything. So if the placenta abruption is bad enough, it's going to result in an emergency cesarean birth. So in general, when we're managing tachysystole, we take steps to reduce the frequency of contractions and ensure both mom and the fetus are safe. And the approach is going to vary depending on the underlying cause of the tachysystole, the severity of symptoms, and whether or not these frequent contractions are actually impacting mom's or baby's health. Okay. So the specific management plan is going to depend on the clinical situation, how labor is progressing, the overall health of how mom is feeling, how baby looks on the monitor. But it is something that needs to be recognized, and intervention needs to happen if necessary. I'm wondering if in the case of your friend, there were so many frequent contractions that the baby couldn't recover in between. So maybe it was like showing up on the fetal heart rate monitor. That's my guess about what happened, because generally we don't necessarily intervene unless it is causing some issues. Now, in terms of interventions or management strategies to manage tachysystole, there are several. One is to discontinue or reduce pitocin if that's going. That's an easy fix. If tachysystole is happening in the setting of labor induction or augmentation with pitocin, then you turn off the pitocin or turn back the pitocin. That's going to allow the uterus to slow down the frequency of contractions. Happens very quickly that it will slow down. It's a bit more challenging to reverse the effects of prostaglandins. If it's something like Cervidil, which is this prostaglandin tape that's inserted into the vagina, then we can remove the Cervidil and it will decrease the contractions. But if it's Cytotec, which is a pill, we can't take that back. So that becomes a bit more of a challenge to reduce the contractions if they're frequent with if they're frequent with Cytotec. But with pitocin, we just turn the pitocin off, okay? We also may do things like reposition you in the bed, turn mom to her left side. That can increase the blood flow to the placenta. And we really don't just limit things to being on the left side. We're going to keep moving positions until we find the position that the baby likes the best. Sometimes we also give extra oxygen as well. We may do IV fluids to help bring up mom's blood pressure if blood pressure is low. So these are all things that'll be happening all at the same time if we're seeing that tachysystole is impacting the baby. And then we need to treat underlying causes. So if it's caused by something like an infection that's happening, because sometimes it can happen there, then we want to give antibiotics for the infection. If it's tachysystole because of a placenta abruption, then we may need to do an emergency cesarean birth because that's the only thing that's going to treat that placenta abruption. And then finally, which is what your friend had, and I just left this as last to transition into talking about it, but it's tocolytics. So tocolytics are medications that can help relax the uterus and slow down or stop contractions. The common tocolytics that we use are either magnesium sulfate, which actually isn't a great tocolytic. We don't use it that much anymore. There's also indocin or indomethacin. There's nifedipine, and then terbutaline. So terbutaline in particular is useful if tachysystole is causing significant fetal distress and it's not responding to the other measures that we talked about. So what exactly is terbutaline? So terbutaline is a medication that belongs to the class of drugs known as beta-2 adrenergic agonist or beta-2 agonist, and is primarily used as a bronchodilator to treat asthma, actually, and other conditions that involve reversible airway obstruction. However, terbutaline is also used in an off-label fashion as a tocolytic agent to temporarily suppress contractions, okay? And off-label, we use lots of medications off-label, and there are a number of reasons for that. I'm not going to get into that particularly deep, but I'll say briefly that one, it's hard to study medicines in pregnancy because there are a lot of regulations around it. Two, it can be challenging to recruit people for studies in pregnancy because who wants to sign up to be in a study while pregnant necessarily? And three, the company has no incentive to go back and do studies now that the medication is already being used regularly in OB care. It's been used for decades and decades, so they don't have any incentive to go back and make it an on-label use. Now, the way that it works is that terbutaline stimulates beta-2 adrenergic receptors, which are primarily found in the smooth muscle of lungs and the uterus. And when these receptors are activated, they cause the muscles to relax. So in the lungs, this will lead to opening of the airways, and in the uterus, it will result in the relaxation of uterine muscle, which is then going to reduce the frequency and intensity of contractions. Now, terbutaline is only recommended for short-term use, okay? Short periods of time to stop contractions temporarily. I'll talk about how I've used it more right at the end, but really for short-term use. It can be given in three ways: oral, subcutaneous, or IV. I have only ever given it subcutaneously, which is an injection right underneath the skin, but it can be given orally or through an IV. When it's given in as a subcutaneous injection, it takes pretty rapid effect. It starts working within 5 to 15 minutes, sometimes sooner, I see in clinical practice. And the duration can last for 1.5 to 4 hours, with the peak effect occurring about 30 minutes to an hour after the terbutaline is given. Now, terbutaline can have some potentially very serious side effects. Some common side effects are tachycardia, which is the rapid heart rate, palpitations, and increased blood pressure. It can also cause anxiety, tremors, headache, dizziness. In long-term use, it can elevate blood sugar, and it can also actually, even though help with breathing, it can also cause shortness of breath or even chest discomfort in some cases. And it can have nausea, vomiting, or muscle cramps. I would say the most common side effects are that tachycardia or rapid heart rate and the palpitations that can come from that. Now, because of the potential for serious side effects, terbutaline, again, is only recommended in the short term, especially in women that have pre-existing heart conditions, high blood pressure, or diabetes. The FDA, in fact, has a warning for terbutaline. It's a black box warning, which is the strongest warning that is available, where they recommend against the prolonged use of terbutaline for the management of preterm labor specifically. So not necessarily short term, like in labor to treat tachysystole, but they recommend against the prolonged use of terbutaline for the management of preterm labor, particularly via injection, due to the risk of serious maternal problems, heart problems specifically, and death. Now, in my personal experience and the way I use terbutaline, it does work great to slow down contractions and help give the uterus a break if there are too many contractions and the contractions are affecting the baby's heart rate. It can also help with frequent Braxton Hicks contractions if they are really bothersome. So that's another area where it may get used. I have never seen Terbutaline stop labor, and that may be because I only limit it to one dose. So it's not something that I ever give repeatedly. Back in the day, it used to be given orally repeatedly. I have not seen that in I can't even, maybe once in my career have I seen it given orally on a repeated basis. So I typically limit it to one dose because of those potential side effects. And because of that, it doesn't stop labor. It will slow down labor, but I have not seen it stop labor. But it does work effectively in slowing down the contractions and help giving the uterus a break in the short term to help the heart rate recover, help the baby get a little bit more oxygen, and kind of perk the baby up for a bit. Okay, so there you have it. I hope this answers your question, Kat. And all of you that are listening, I hope you subscribe to the podcast in Apple Podcast or wherever you are listening to me right now. And if you have a question that you want me to answer in an upcoming episode, shoot me a DM on Instagram. I'm on Instagram at Dr. Nicole Rankins, or you can send it to me on my website at drnicolerankins.com/contact. That is it for this episode. Do come on back next week and remember that you deserve a beautiful pregnancy and birth.